Mr. Chairman, ladies and gentlemen, thank you for the invitation to talk. My disclosures. And first, if you want to talk about stenting the arch, I think you have to look at the gold standard, which is open repair. And here in this report, it's a systematic review of the literature. I think the open results are quite good, but you have to realize they're all retrospective observational studies without control, so probably a huge publication bias. If you look at stenting in the arch, this precise deployment of the stent graft is difficult because of anatomy and physiology. In the anatomy, of course, we have the aortic arch, which can vary in form. Tortuosity, side branch location can be difficult, even to do a right angio to project the side branches. If you look at physiology, you have three things. Of course, the windsock effect of the half-open stent graft and the positive flow of the blood. We have all kinds of tricks to compensate for that, and in this report, especially the rapid pacing is looked at and found the best way to do this. All of you know better than I do that in TAVI the route is going up and down. And it's the same if you go from aortic arch stenting. There's a lot of movement in the route, but also a little bit higher up in the arch. And in the lower picture, during rapid deployment, you have a nice stable situation. And here, during a branched arch device, rapid pacing, you can see during deployment the arch is not moving at all. Not so recognized is respiratory movement of the arch. And this is a phenomenon which has been looked at here in healthy people. And you see the ascending aorta and descending aorta both move quite a lot during in an expiration. You can reason that during in the sick aorta, more fibrotic, that should be less, but that's not true. Here in this report, you can even see that respiratory movement of the arch is almost 3 times larger than cardiac movement of the arch. We also looked at this in 60 patients where we did a CT scan in maximum inspiration and expiration and did a comparison, and you saw that here in blue the brachiocephalic trunk and left carotid and left subclavian orifice quite moved a lot in 3 directions. And if you translate that in 3D vector, it's almost 1 centimeter movement in the arch, which you have to be aware of during deployment of your stent graft. This is just an animation I made, and if you see the red line where the common carotid artery is, this is not what you see when you're deploying a stent graft, but this is how the arch moves when the patient is breathing. And so what we do is during arch deployment, we shoot our angio with breath hold, and we also deploy our stent graft with breath hold, just to have a stable position. If you want to look at arch stent graft, you can classify the level of proximal seal by the Ishimadu classification, where in zone 4 is the straight proximal descending part. Zone 3 is up to the left subclavian artery. Zone 2, when you cover the left subclavian artery. Zone 1 covering the left common carotid, and zone 1 is when you go into the ascending aorta and cover all 3 vessels. And if you talk about endovascular repair, there are 2 ways. You either can do debranching with TVAR, and you saw some pictures of that, or you can do total endovascular repair. But you have to be aware, in most total endovascular repair, there is some extra anatomical debranching involved. So first, the debranching options, and I come to that. And here there is a good reason for revascularizing the supraaortic vessels. And of course, if you for revascularizing the left and right carotid artery, avoiding brain ischemia, but also the posterior brain ischemia is important. And you have to look at if there is a dominant left vertebral artery and you have an extra problem where you have a solid when it divides from the aortic artery itself. The first vertebral artery also involved in spinal cord ischemia, so important for that. And here 3 other cases like Lima Day bypass, hemodynamic fistula in young left arm patients are good reasons to revasculate the left subclavian artery. So if you have to cover zone 2, left carotid subclavian bypass of transposition is the simple way to go. A little bit further on is a carotid left subclavian bypass. And if you have to go into zone 0, full aortic debranching is a way to go. Yeah, probably for you guys it's a small operation, but I think it's much more invasive than the options, the other options. And in my opinion, it's usually difficult to reach the left subclavian artery. So if you use this kind of hybrid graft, rod by bore, it's much easier to revascularize all patients. And you can also here a pacemaker wire to use to mark your proximal landing zone for your stent temporarily. This total debranching and stenting has been compared to total open arch repair, and it doesn't really matter if you look at mortality. A little advantage for the endovascular repair, but not significant. If you look at neurological deficit, open repair does better than the endo, but also not statistical significant. If you look at total endovascular repair, there are 2 options. Stent grafting with chimneys or total or branch or fenestrated. The chimney technique here shown in a systematic review, 5 articles with 51 patients, and you see that in the middle on the left side, most of the chimney grafts were single chimney grafts. Even if they were in the anomaly artery, there was still single grafts. Perioperative mortality, I think, was almost 6%, quite high, and rather high stroke rates. So, and one of the issues of chimneys in the arch is endoleaks, and especially type 1, so the proximal type 1 endoleak, and you can understand that because if you put a chimney next to a stent graft, you have gutters, and these gutters are the reason for the high endoleak rate. Here, an example in our practice, quite a young patient with multiple sclerosis, which was turned down for open repair, and we put a carotid subclavian bypass chimney in the anomaly artery, and on the right the CT scan 6 years later with no aneurysm anymore. So in this patient, a good result. If you're going for total endovascular, you can either use branches or fenestration in the arch. Branches are the early result. These are the results of the Malmö clinic in Sweden, and what they concluded, it's both feasible to use fenestration and branches. Branches more in zone 0, so total arch endovascular repair, and the fenestrations were associated with higher mortality in their series. In 1999, there was the first publication about total arch repair using this Japanese stent graft. And he had a series of 15 patients, and in this series, only one had a 3-vessel branched fenestrated stent graft, but it's, it looks quite neat if you looked to stents nowadays, but it worked well. Which stents do we have here? These two from Gore and Medtronic, single branch stent grafts are still under clinical investigation. The Gore graft you can either use in the left subclavian, but also one who can be used in a non-omit artery. And more clinical use is here is the Bolton double branch graft, where the branches are put in through the supra-aortic vessels, and the Bolton delivery system is quite useful in this kind of patient, because it has a very smooth polyester inner sheet which tracks beautiful through the arch. A new kid on the block is the Nexus device, where it's a little bit different, where the stent graft goes from the innominate artery into the descending. I made a very quick animation of it. But you see that there's an additional ascending graft which is connected to it, and an extra stent in the carotid artery. And this stent graft is still under investigation. I think most worldwide use is the Cook system, and also the only system I have experience with, which is also a system with two branches incorporated, two inner branches which are connected to the arch vessels from above. As you can see on this technical drawing, the stent graft tapers at the level of the branches, giving more room for the branches, so you can easily cannulate them from above. In this publication, 3 users combined their clinical outcome in this graph. What you can see is that they mostly use this kind of grafts in post-type A dissection patients, and so in 70% and 30% still dissection in the arch. Cerebrovascular events, 2 major and 1 minor stroke, a little bit high, and mortality rate of 70. And because it's used in a lot of second stages, let's say in post-type A dissections, the group of Stéphane Long and Liu looked at their post-type A patients, how many would be suitable for this kind of device, and they came up with 71 patients. And the reason for unsuitability were all too short graft, kink in the graft, and grafts which were too large to put a stent graft in. So if this becomes the way to go in the future, it's something I guess you have to think of. You have to think ahead to make it possible to put in an arch device. Here, an example of a patient was treated in our clinic post dissection, post type A dissection, with a 2-vessel branched and a carotid subclavian bypass, with thrombosis of the false lumen up to the distal level of the stent, and in the last CT, reduction of the diameter of the aorta. So successful up to now. Of course, there are obstacles for endovascular arch repair, and that's one of the main things is the complexity of arch anatomy. Aberrant branches, significant tortuosity are difficult. We have to be aware of possible graft failure in the future, because there are extreme forces in the arch, and I think especially the chimneys are at risk for that. And one of the, I think the main obstacles is ascending aortic disease, because the ascending aorta is the proximal landing zone. It's usually a little bit wide and already sick, and also grafts in the ascending aorta, if they are too wide, too sick, or too kinked or too short, it could be a problem. Large devices up to 24 French, so you have to have a good iliac access to reach the arch. So that's also a problem. So in conclusion, I think open repair is still the gold standard. Endovascular repair is feasible and certainly an option for high-risk patients. One of the advantages of TEVAR with chimneys is that it's an off-the-shelf procedure, so it's available for acute cases. And I think in the future, total endovascular arch repair will become the procedure of choice in most cases. Thank you.